So, hi everyone, very good evening to all. Just please confirm if the audio and video is fine. Once you confirm it, I think we are good to go. Okay, so just check the audio and video and let me know. All right. So, today I'm just going to take up the first part of your PYTs of orthopedics, and I'm very sure that each one of you is having this file with you, right? And this is the file we have. Okay, let me just open this up. So if the audio video, if it is all fine, please confirm that so that we can start now. Yeah. Okay. So uh, all right. Yeah. So good evening, everyone. Now I'm able to see. Okay. So Utkarsh Utpal is saying आज फिर से traffic ना लगे तो भाई आज traffic नहीं लगा. I was here on time, but it took me some time because I'm doing a YouTube session after a long time now. It was a long break. Okay. And orthopedics में आग नहीं लगानी है. You just have to understand the basics of the orthopedics. Or yeah, all clear. Thank you so much, Rohan. I was not able to see the chat section, so I was just waiting for some time. Okay. And Amrut, it will be good if you can make some good notes and whatever images I'll be showing you, I'll be sharing that with you, right? So images I'll share, but for that you will have to keep on writing along with me. So once you write, I'm sure. See, when you start writing, no, it always gives you a very good habit. Like you remember what you have written. Okay, and that is definitely going to be very beneficial for all of you, right? So, guys, this is one file which we have shared with you, FMG PYTs. I'm sure that each one of you have saved this file with you. This has been shared in the Telegram group of Triple S. Okay, and now this one, the PYTs which I have, these are all the questions which have been like taken up, the topics which have been taken up from your previous few years, starting from the year 2020. All right. So now I'm just going to share with you how I have to read. So today it is going to be part one only. I don't want to take, yeah. So, okay. So I'll not be taking the whole orthopedics today that we keep on going for hours and hours. It's not required. So today I'm going to cover up some part of trauma so that you are used to just hear what I have to say. You're used to write down the notes and you're very well prepared for your June exam or the December exam, whatever you might be going for. And please understand, when you're going for orthopedics, it is not just orthopedics. Ortho has its base in anatomy, right? And ortho has its like straight integration with the radiology part. So whatever X-rays we are going to read, whatever images we are going to see, they will be the questions of your radio as well, right? And the base has to be in anatomy. When you talk about joint disorder topics, they are supposed to be taken up with your medicine as well. So integration is always there, right? So let me just start with this. Good to see you all at this time. So today this sheet is, I'm sure, with all of you. And today I have decided to take up this trauma section, right? One of the very interesting and a very straightforward, the questions which are asked from this topic, very easy scoring things. So I'll be just taking up a few injuries today. So we can start up with the Colles and Smith. We can go to the Monteggia and Galeazzi. We can talk about Supra condylers, lateral condyle. So these are four injuries which I want to take up today, and they are actually very interesting one and very important one as well, right? So let me show you all of them. Let me show you all these injuries, and let's see how the questions are asked in your FMG examination. All right. So Colles and Smith. Let's start with that. The Colles and Smith. So everybody, each one of you can start writing along with me. And yeah. So along with me, and I'll first show you the Colles and the Smith and how to differentiate them. See, when you talk about the very, very basic concept I'm taking here first, when you talk about the fractures here at distal end of radius, okay, the very important concept, the fracture, when you talk about the fractures of the distal end of radius, okay, distal end of radius are of usually two types, right? They can be of two types. Either they can be like extra articular, they can be, okay, they can be extra articular or they can be intra-articular. Now, what exactly that means? Now, if you like one advice, guys, before I'm starting giving you the notes, one advice is please don't try to mug up anything. Try to understand and trust me. Once you understand the concepts, you are never going to forget any of the MCQ of the orthopedic part. Okay, so intra and intra-articular. One is extra-articular, one is intra-articular. Now, when you are saying intra-articular or extra-articular, what exactly that means? See, distal end of radius is somewhat like this, the distal end of radius, and this is how the ulna is, right? And these make articulation with the carpal bones, the scaphoid here. Then we have the lunate here, right? And when you talk about the distal end of radius, ulna, scaphoid, and lunate, don't forget that the hand, when I'm waving my hand, the wrist joint is this one, right? This is what you call the wrist joint. What exactly is the wrist joint? Wrist joint means the joint which is made between the radius and the carpals, that is radiocarpal joint, right? Please don't forget that ulna, the ulna bone here, it has no role to play in the wrist joint. It is not a part of the wrist joint. Wrist joint is radius and ulna only, right? So when I'm saying the distal end of radius, it can have the fractures which are extra-articular and which are intra-articular. Okay, so distal end of radius here, again I'm drawing it. Extra-articular fracture means which stay away from the articular areas, right? And intra-articular fracture means that when the fracture line it get into the joint area, see, like this. Okay, so what are the extra-articular fractures we know? Extra-articular fractures like this, they can be Colles. The first and the most important fractures for any of your exam is Colles, and the second fracture is Smith. So Colles and Smith, they always occur away from the joint areas, right? Colles and Smith, they always occur away from the joint areas. And on the other hand, there are two fractures which go into the joint areas. The two fractures which go into the joint areas. What are those? One is Barton. Okay, one is Barton's. Okay, I'm writing other one here only because that will be hiding behind my this image which is coming on the screen. So other one is called as Schoffer. So one is Barton and other one is called as Schoffer, right? So Barton's and Schoffers. So we have four fractures at the distal end of radius, two intra-articular and two extra-articular, right? So when you talk about Colles and Smith, this is the usual MCQ of your FMG examination. The Colles and Smith, what is the basic difference? Colles and Smith are two people who are working in the same university, right? And when you look at the two fractures, how do they differ? How do they differ? See, Colles has got typical displacements related to it. Colles has got typical displacements. How many displacements are there in Colles? So, one, you can have six displacements in Colles, which can be easily learnt by the simple mnemonic that is LIDS. L, I, D, and S. L here stands for lateral displacement, lateral displacement, and lateral tilt. Okay, lateral displacement and lateral tilt. Okay, I here stands for impaction. I here is impaction. D here stands for dorsal displacement, dorsal displacement, and dorsal tilt. Okay, dorsal displacement and dorsal tilt. And S here stands for supination. S stands for supination. So now these are six displacements which are seen in Colles. Now please remember a very, very interesting and important fact about any fracture and any dislocation. All the time, all the dislocations or displacements, I'm repeating this line, be very, very attentive here. All the time, all the displacements, all the dislocations, they are always defined by the final position of the distal fragment, right? By the final position of the distal fragment. What does that mean? Like in the radius, if you see, this is my whole radius. So in this is going to be my proximal fragment, the fragment towards me, and distal fragment is this one, the small one. So all the six displacements that we have mentioned over here, they are going to happen in the distal fragment only, right? They are going to happen in the distal fragment only. So whenever the distal fragment goes laterally, whenever the distal fragment goes into impaction, whenever the distal fragment goes into dorsal displacement and supination, we are going to call it Colles, right? So when you look at the point number three, it is the most important and the simplest way to differentiate between Colles and Smith, right? Where is the distal fragment going? I told you the small fragment. Where is it going? It is going dorsally. Look at this. It is going dorsally, right? This is the dorsal displacement which is happening. Dorsally means when you look at the lateral view of the wrist, this is the palmar side and this is going to be the dorsal side. So now whenever after the fracture, the small fragment goes on the dorsal side, this side, it is going to be called as Colles, right? And Smith, what is that Smith now? So Smith, please remember, Smith is just reverse of Colles, right? Smith is just reverse of Colles. What does that mean? Everything which is happening here is going to be reverse in Smith injury. So when the fragment goes instead of dorsal, instead of coming on this side, if the fragment goes on the palmar side, if the fragment goes on the palmar side, it comes on this side, we are going to call it Smith, right? So for the palmar displacement or the dorsal displacement, what view would you like to have? It has to be a lateral view, right? And if you now look at the two x-rays here, look at the x-ray A and look at the x-ray B. Okay, in the x-ray A, you can see here, this is the shadow of the thumb. This is the shadow of the thumb in x-ray B. So thumb means whenever you are taking an x-ray of the wrist area, the thumb always has to be in front of the fingers. That means thumb is always on the palmar side. It can't be going on the dorsal side. Anyhow, it can't be going on dorsal side, right? So whenever on whichever side is the thumb, it is the palmar side. Now look at this. When you look at X-ray A, you can appreciate that the distal fragment here, the distal radius distal fragment here, it is tilted towards which side? The palmar side. Once it is palmar side, tell me very quickly what it is. If the fragment is on the palmar side, what it should be called as? And the image B, what you can see? In the X-ray B, what you can see is the distal fragment is tilted on the dorsal side. Distal fragment is tilted on the dorsal side, right? So when the fragment is going dorsally, tell me very quickly. Okay, Utkarsh is very quick to answer about the deformity. That is true. But first tell me the diagnosis, right? First tell me the diagnosis. What is the diagnosis of X-ray A? When the fragment is going on the palmar side, what should I call it? Palmar side means the fragment is going on the palmar side, so I should be calling it Smith fracture, right? This is going to be Smith fracture. And if the fragment is going on the dorsal side, we are going to call it Colles injury, right? We are going to call it Colles injury. Okay. So X-ray A is Smith, X-ray B is Colles. Now, as Utkarsh said, like there is a dinner fork deformity. What exactly that means, dinner fork deformity? Look at this image here again. Look at this image here again. This image here, when you look at distal radius, when you look at this distal radius, there is a hump which has been created on the back of the wrist area, this one. Now this hump, if you keep the dinner fork, if you keep a dinner fork upside down, right? This is how it looks like. So this deformity here, which you have in the image number B, this deformity here in the image number B, this one is called as the dinner fork, right? So that is the reason why Colles comes up with a dinner fork deformity. What is the meaning of the dinner fork? Like if you turn the spoon, the dinner fork actually upside down, you will see there is a hump on the back of the dinner fork, right? On the other side, if you look at, on the other side, if you look at the fragment here, it is suddenly giving you a depression over here. Now this one, this kind of appearance is what we call as the garden spade deformity, right? This deformity is now called as what? The garden spade deformity. Okay, so I hope you all will be able to identify the Colles and the Smith fracture. So Colles is going to come up with the dinner fork deformity and Smith is going to come up with the garden spade deformity. I hope it is fine with everyone. The Colles and the Smith, right? The Colles and the Smith. That is a way to differentiate. So please don't forget that the Colles and the Smith area. That's how you have to identify that in your exam as well, right? So I hope this should be very clear. Garden spade, Smith fracture, perfect, perfect. Everybody's right, right? So that is your first MCQ. Colles and Smith, how to identify, right? And treatment for both of them has to be conservative. You have to give plasters only. How to give the plaster? How to give the plaster? I'm just putting it here. That treatment for both of them, the Colles and the Smith, it has to be conservative. You don't have to go for surgery in any one of them, right? You don't have to go for surgery in any one of them. It has to be conservative only, right? That has to be absolutely conservative. Okay, that has to be absolutely conservative. All right, this is fine with everyone. So, is this fine with everyone? Shall I move on to the next one? Another very, very important topic. Shall I go ahead with that? So, second one, what did we have the second one? Second one we have is the Monteggia and Galeazzi. Okay, Coley Smith, everyone, Utkarsh, Amrut, Naga, John, everyone. Shall we go on to the next one? Yeah. So plasters I'll take at a time. Special applications of plaster I'm going to take up at a time. Just hold on for some time. So now this is what I was talking about. Now as you have said about this, Utkarsh, let me just take it up here only. So this is the reason for the dinner fork, and this is the reason for the garden spade, right? So treatment, yes, as Utkarsh said, when you are giving the plasters, it has to be given in the handshake position, right? It has to be given in the handshake position. Absolutely, you are absolutely correct, right? Now, coming on to the next one. Next one is about the Monteggia and the Galeazzi. Let me show you that as well. The Monteggia and Galeazzi. Now, see, I'll show you two most important injuries here. These two. Look at this. The very first X-ray, very very important one. Okay, this X-ray on your screen is called as Monteggia, right? This injury is called as Monteggia. How do I remember Monteggia? How should I learn about Monteggia? See, Monteggia fractures, what does that mean? M. This M is for medial bone, right? This M is for medial bone. Remember it like that. In the forearm, you know that we have got two bones. Medial side it is ulna, lateral side it is the radius, right? So lateral radius, medial side ulna. So when there is a fracture of the medial bone, the fracture of proximal one third, the fracture of proximal one third of ulna, fracture of proximal one third of ulna with dislocation, with dislocation of distal radioulnar joint, fracture of proximal one third of ulna with dislocation of dislocation of the proximal, not distal, my bad, of proximal radioulnar joint, then we call it Monteggia. Now see, both the things are proximal. How? If you look at the X-ray, this is ulna bone here, this is a radius bone here. So fracture of proximal one third of ulna, fracture of the proximal one third of ulna, and which is keeping the proximal radius also dislocated. Okay, so proximal radioulnar joint and medial bone, that is ulna. So proximal one third of ulna. Okay, so medial side, yeah, medial side, it has to be about the Monteggia injury. Okay, so this is Monteggia fracture, right? So please remember, medial side, proximal area, proximal radioulnar joint, right? Medial side, proximal area, proximal radioulnar joint, right? When you look at the other X-ray now, look at this one, look at this one. What do you appreciate here? Here there is a fracture of distal one third of which bone? This is radius now. Fracture of distal one third of radius now, and this one is ulna, right? So fracture of distal one third of radius along with dislocation of the distal ulna. This is called as reverse of Monteggia. The previous image and this one is just reverse of that. Can you see that? This one is called as Galeazzi, right? This one is called as the Galeazzi fracture. Now, what is that Galeazzi fracture? How do you define that? Like I said, it is reverse of Monteggia. It is reverse of Monteggia. Okay, reverse Monteggia or Galeazzi. How do I define it? Reverse Galeazzi, this reverse Monteggia or Galeazzi now. So it is a fracture of, this hashtag sign is for fractures. So fracture of distal one third of radius, right? Fracture of the distal one third of radius with dislocation, with dislocation of distal radioulnar joint, right? Just reverse of what you have seen in Monteggia. So fracture of distal one third of radius now. So Galeazzi is the fracture of the lateral bone. Monteggia is the fracture of the medial bone, right? So medial bone injury and lateral bone injury. That is the difference in Monteggia and Galeazzi. So you all can easily differentiate now Monteggia and Galeazzi. Everyone. So Galeazzi, Monteggia. I'll share all these pictures in your group as well. Don't worry. These X-rays I'll share in your groups. Okay. So Monteggia and Galeazzi, right? So these two should not be missed at all. Next ones are the supracondylar and the lateral condyle. Two very very important injuries for your exams, right? Two very important injuries for exam, Galeazzi, Monteggia, and now let's come on to this one. Now see, one very very important injury we have is this one, supracondylar fractures, right? First of all, understand these are three X-rays. X-ray A is there, X-ray B is there, X-ray C is there, right? When you talk about supracondylar, first you have to understand that supracondylar is what part of the bone, right? In the supracondylar area, this is the shaft area, that is a diaphyseal area. This is the metaphyseal area where the fracture is actually happening, and this is the end, the epiphyseal area, right? Why supracondylar fractures are so important? Why they are so good and so bad at the same time? Because supracondylar area, condylar means this is ulna, this is radius, this is the capitulum, right? This is capitulum, and this hole is trochlea, right? This is trochlea, this is the medial epicondyle and the condyle, right? And this one is the lateral epicondyle and the condyle, right? This is the lateral side, this is the medial side. Okay. Now, when you're talking about supracondylar, that means above the condyles. Supracondylar means above the condyles. This is the metaphysis of the long bone, right? This supracondylar is actually metaphysis of long bone, right? And why metaphysis is so important? Why metaphysis is a wonderful site? Reason being, metaphysis is a very, very vascular area. So healing chances are always very, very good, right? And this is the reason high vascularity, good vascularity, cancellous bone, soft bone, so heals very, very nicely, right? So healing occurs very nicely. Healing occurs nicely, right? So healing has to be very, very nice. Metaphyseal area, high vascularity area, and healing occurs very, very nice. That is the reason why, that is the reason, please remember, the most commonest complication, if somebody asks you, the most commonest complication related to supracondylar humerus, metaphyseal area, it always has malunion, right? Please understand this word, malunion. Malunion seems like a problem, isn't it? Yes, it's a problem. But is there something good in this problem? Is there anything good in this problem? Yes, there is something good. What is good here? Good is union. Good is union. And what is bad here? The bad is malpart. So whenever the bone is not uniting in the anatomical position is what you call as malunion, right? It is always not a trouble. Sometimes it is okay. Sometimes it is not okay, right? So supracondylus, please remember one of the question of your exam, most commonest complication has to be malunion, right? Most commonest has to be always malunion, right? But please also remember that there is one very interesting concept in the elbow, and that is about the 3-point relationship. 3-point relationship. Now, what is that 3-point relationship in supracondylar? What is that so important in 3-point relationship here? See, on the back of my elbow, if you look at this central point is olecranon. I'm keeping my thumb on my medial epicondyle and the index finger on the lateral epicondyle like this. So we can do it like that. The index finger, keep it here, olecranon, thumb on the medial epicondyle and middle finger on the lateral epicondyle. Now when you see this, these 3 points are making a triangle. These 3 points are making a triangle on the back of the elbow, right? Now whenever the elbow will be extended, all the 3 points will be lying in the straight line, right? So there is a triangle which is formed when the elbow is flexed. Okay. Now, if they ask you this question, these are 3 points here. That is the olecranon. I'm putting it here. Olecranon, medial and lateral epicondyle. So triangle has to be somewhat like this, right? They ask you that what happens to 3-point relationship in supracondylar fractures. Now see, supracondylar fracture is happening above this triangle. That means there is no change. That means there is no change in triangle in supracondylar fractures. Right? There is no change in the triangle in fracture supracondylar humerus. So please remember two most important points about supracondylars, that malunion is the most commonest complication, and second, there is no change in the 3-point relationship because the fragment is getting injured, the bone is getting injured above the triangle, right? This is very very important. Please don't forget that. right? Please don't forget that, right? Supracondylar humerus. Okay. Similarly, now I come on to the next part. Similarly, when you talk about the next injury, let me show you that as well. When you talk about this injury, okay, the lateral condyle. Now, what is so important here? Now, this one is radius, this is ulna, this is capitulum, and this is a fracture of the lateral condyle, right? You always, guys, please remember that lateral condyle here, which you can palpate very well on your elbow. Lateral condyle gives attachment to the common extensors here, right? This is common extensor origin, right? This is common extensor origin. This is the origin for common extensors of the fingers, right? Now, whenever you talk about lateral condyle, always remember that lateral condyle injuries are also called as the fractures of necessity, right? They are also called as what? The fracture of necessity. What is the meaning of that? Fracture of necessity. Fracture of necessity means those injuries which requires fixation all the time, right? Surgical intervention. So fracture of necessity means which needs fixation always, right? Which needs fixation always. Now the question is why lateral condyle should be called as fracture of necessity? Reason is very simple, because there is a common extensor attachment, and because of these common extensors, extensors going to your fingers also. So whenever there is an attachment of common extensor, it will never allow the fracture end of the bone to stay in connect with the parent bone, and that is why if you don't do the fixation, if not done, if the fixation is not done, what is going to happen? Fragment will not unite, and that is why the lateral condyle has the most commonest complication as what? Non-union, right? Another MCQ of your exam. Lateral condyle fractures are related to what kind of complication? They're related to non-unions. So supracondylars are related to malunions, right? Lateral condyle is related to non-unions. Okay, this is the reason. So concept has to be very, very clear. Metaphyseal area will unite for sure. Fragment is connected to the common extensors. They will never allow the bone to stay in place. They'll keep it mobile, and therefore it never unite to the parent bone. And that is why it is called as fracture of necessity. The treatment always has to be fixation, right? The treatment always has to be fixation. Okay. It is Utkarsh. It is not always Salter Harris type 4. Lateral condyles are usually Salter Harris type 2 followed by type 4. Okay. So lateral condyles can be of both the types, Salter Harris. I'll discuss Salter Harris also with you. I'm discussing all the PYTs. So Salter Harris, I think, is an important and interesting thing and area to be discussed. Okay. So these are certain injuries, guys. I'll keep today's session very, very short. Just wanted to know like how many are actually giving the June exam. So all of you who are here, Utkarsh, are you giving the June exam? Sham is there. I can see Amrut is there. John is there, and Naga is there. Okay, are you all guys giving the June exam? Is it like that? So just tell me, shall we just continue with the same PYT series, because the next one it has to be a bit longer one. I'll be taking a long hour session and I'll be covering up most of the important things. Okay, so shall we continue with the series like this only? The PYT part 1 is done today. I'm just taking these 4 fractures today. Next time I'm going to take up all the clinical integrated part of proximal humerus, shoulder dislocations, fracture neck of femur, which has been a recent question in your INI set exam also. So if there is a question in your INI set, please do expect that question in your FMG as well, right? The concept, the topic has to be, yes, everybody's on the 6th July, right? Perfect. Okay. So in the next session, I'm going to cover up these 3 injuries, along with that peripheral nerve part, right? And along with that, these two are the big topics, and I would like to take that very, very nicely with you. So next part 2, I'm going to take up these 2 sections. Okay, the proximal humerus, shoulder dislocation, neck femur, and peripheral nerve injuries, right? I'll take up that nerve part, enterintrotious nerve, what you're telling, Amrut. I'll take that in supracondylus part. But that peripheral nerve injury, I want to take up that very, very nicely, because there are a number of questions which they ask you from here. Okay, so just send me your like reviews for these particular session of orthopedics as well as the anatomy, because nerve is something which is coming from anatomy only. Metabolic disorders from your pedia also, from your medicine point also, and then we have some more, the bone tumors, pediatric disorders, joint disorders, deformities. We have so many things, right? So I'll be discussing all of them one by one. today's session, I just want to keep it like very, very short, kind of 40-45 minutes. So this is all I'm going to take up today. Okay. Okay. So let's see how you all will be benefited by these sessions. I'll try to just plan up the next one and I'll inform you very, very soon. Tomorrow, I'm going to have a class outside Delhi. So I'm going out. And after that, 4 days, after today, 4 days continuously, I have a class. So it will be a little tough to connect with you. But after that, definitely I'll plan a session, same time around 9 o'clock. And that day, we are going to cover up the nerves and all the three topics of trauma as well. All right. So till that time, guys, just stay on the track, follow the schedule that you have made for yourself, and I'm sure that Triple S group is able to make some little difference in you and your studies. So just keep yourself on the track, keep yourself positive and hopeful, and see you some other time, another time, like in next 4 or 5 days after my classes are done. So 4 days I'll be in class. Fifth day maybe we can connect again, and I'll just inform you prior, right? So PYTs we are going to discuss here only, and maybe tonight I think I'm going to share one more PDF. Maybe today or maybe tomorrow I'm going to share one more PYTs with you. So keep them safe and just revise all the topics when you are going for the 6 July exam. So right. So thank you so much, everyone. Have just keep studying. Right. Have a wonderful time. See you again after like 4 or 5 days. I'll keep you updated. Okay. Thank you so much, everyone.